chains.
Be with symptoms. And Dr. Chris Flowers from Emory University, who's the director of the lymphoma program there, associate professor and bone marrow transplant also, is going to tell us about options for relapse therapy. Chris, welcome.
Great. Well, thank you, Stephanie, and thank you to the organizers for having me present at this wonderful conference on World Lymphoma Awareness Day. But most importantly, I'd like to thank all of you, the audience, who have come out here to spend your Saturday with us. And so I am given the task to talk about options for relapse. I will spend most of my time talking about options for stem cell transplantation and defer some of these topics to other presenters, some of which you've heard about in previous presentations and some of which you'll hear about later on in the day. And these are my disclosures, which are included in your handout. So, as you've heard throughout the day, follicular lymphoma really requires a comprehensive management approach. For every individual patient, there's an individual path through the management of this disease. And you've heard a little bit about patients who have advanced stage disease with low tumor burden, where observation is an appropriate course of action, and heard some data about single agent rituximab for those patients. You've heard some about advanced stage high tumor burden patients where therapy needs to be individualized, and there are a number of chemotherapy options with rituximab, as well as the role of clinical trials. And you've heard about one very important clinical trial from Dr. Rummel this morning that are making new advances in that disease. We haven't spent much time talking about localized disease, and I won't spend any time talking about that as well, but we're happy to take questions in the panel and elsewhere. And you've heard about some options for maintenance and consolidation. What I will spend most of the time talking about is what happens at relapse, both in the initial relapse after an upfront therapy or after maintenance therapy, and second and subsequent relapses of the disease. So you saw at the outset the GELF criteria, or the criteria that were set forth by the French group, and criteria that have been set forth by the National Comprehensive Cancer Network as to when it is appropriate to initiate therapy. When a patient relapses with follicular lymphoma, these criteria come into play again as to when it is appropriate to initiate therapy in that second line setting. And you heard about many of these criteria at the beginning of the talk for defining who has low tumor burden and who has high tumor burden. And each of these criteria come into play again when trying to decide for whom it's appropriate to have start a second line therapy. There are a number of conventional strategies. You've heard about some of these in the front line, combining rituximab with chemotherapy or chemoimmunotherapy regimens. You've heard about chemoimmunotherapy followed by maintenance. You've heard about rituximab as single agent, either with or without maintenance therapy. We haven't talked much about radioimmunotherapy, but that is another agent that you'll hear a little bit about in Betsy DePerry's talk that is appropriate and approved in the relapse setting. And I will spend some time talking about these two forms of transplantation. Later on in the day, you'll hear from Dr. Schuster, who's talking about novel strategies both in the upfront setting and in the relapse setting. And many of these same agents that we talked about, or regimens that we talked about in the upfront setting, are also appropriate for patients who have evidence of relapsed follicular lymphoma. What I'll spend the rest of the time focusing on are autologous and allogeneic stem cell transplant and the role that those play in the management of follicular lymphoma. So in terms of autologous stem cell transplantation, this is a modality of therapy that really depends on the use of high-dose chemotherapy or the combination of high-dose chemotherapy and radiation therapy, using that for an anti-tumor effect with the hope of using the high-dose therapy to completely eradicate evidence of lymphoma or to put patients into complete remission. When you look at the recent history of autologous stem cell transplantation, this is a modality that has become safer and safer over time. When I was back at Stanford, or when I was back at the Fred Hutchinson in the practice of transplantation, this was a therapy where we talked about the risks of dying from the transplant itself being somewhere in the 5 to 10% range from the intensive chemotherapy that occurred. In the last decade, or since from the 1990s or from 2000, that rate has dropped down to about the 5% range. And in many institutions, including our own, where we've looked recently, that risk of dying is now down to less than 5%, or about 2% in our institution. And for the vast majority of patients, this is including all autologous transplants, not just for follicular lymphoma. The majority of patients that had complications were complications related to diseases other than just their lymphoma that they had going into the transplant. The other thing that is a challenge, though, with autologous stem cell transplantation is that you're collecting the stem cells from the individual prior to the transplant, and there is the potential for contamination of the graft by tumor cells. There have been mechanisms to try and help avoid that, like giving rituximab during the process of collection that help to, in effect, cleanse the graft from that. And there are additional late complications that I'll talk about, such as secondary cancers that you heard about following chemotherapy, like myelodysplastic syndrome, or MDS, which can progress into acute myelogenous leukemia. And there are potential other organ toxicities to the lung, to liver, and sometimes in terms of mental compromise following the completion of therapy. I think some of the key questions that now exist for patients with follicular lymphoma is when in the course is this a most appropriate therapy, and which patients are most likely to benefit. And I'll address some of those points. So this is a trial that helped to establish the role of autologous stem cell transplantation for patients with follicular lymphoma. And this is a trial called the CUP trial, where it compared two different approaches to autologous stem cell transplantation. So these were all patients who had relapsed follicular lymphoma and then had additional chemotherapy to treat their disease and to put patients into remission. Patients who had a complete remission or a partial remission then went on to be randomized either to have one of two forms of autologous stem cell transplantation or more cycles of chemotherapy. In this trial, one of the aims of the trial was to address the question that I mentioned on the last slide, and that was the role for tumor contamination of the graft. And the way this trial attempted to do this was to take the stem cells and to purge the stem cells, attempting to remove the cancer cells from the graft, or to perform the stem cell transplant with an unpurged stem cell graft. What happened in the actual conduct of this trial is that there were relatively too few patients that had either one of these approaches to compare them to each other. And so ultimately, in the analysis of this trial, these two groups got merged together to compare transplantation versus proceeding without transplantation. And what you can see here, this is another Kaplan-Meier curve that, as Brad mentioned at the beginning, is something us oncologists all like to do in terms of being able to compare how trials work. And what's shown here on the y-axis, or up and down, are the percentage of patients that are alive and free from progression over time. And shown here across the horizontal axis are the number of months that patients were followed. And what you can see is that when you combine the two groups of purged stem cell transplant and unpurged stem cell transplant, that this combined group of stem cell transplant fared better than those patients who had chemotherapy as their approach. When you look at overall survival, there is a suggestion also that there is a benefit for purged stem cell transplantation and unpurged together compared to chemotherapy. Now, one of the other questions that still sits out there is which patients are most appropriate for autologous stem cell transplantation. And there is not really a definitive answer to that question for patients broadly, and these are decisions that need to be made on an individual basis. There have been a number of retrospective studies that have looked at this, and like many other therapies, for patients who are undergoing stem cell transplantation, using the transplant is better if it's used earlier rather than later. But this was an attempt by Julie Vose to try and look at factors that are known as predictors of who tends to do better or worse with stem cell transplant. And in this study, she identified three factors: the grade of follicular lymphoma that you heard out from Brad at the beginning of the session today, the FLIPI score, and the number of prior regimens. Again, getting back to this point that when it's used earlier, patients tend to fare better. And if patients had one of these particular factors, or two of these factors, or all three of these factors, they tended to do worse than patients that had none of those factors when an autologous stem cell transplant was performed. The other issue that comes up is the role of secondary cancers, and here are the risks in a retrospective study that comes from the German group looking at autologous stem cell transplantation compared to interferon used as a maintenance therapy for patients with follicular lymphoma. And you can see here that over time, that risk of secondary malignancies like myelodysplastic syndrome and AML is a cumulative risk that occurs over time. So as patients are followed out after therapy, that risk tends to mount up over time, with an average risk of being somewhere between 2 and 5% per year. So in thinking about autologous stem cell transplant as a whole, this is a modality of therapy that can produce long-term disease-free survival, and that's a term that you've heard multiple times throughout the day. It is not a curative modality in and of itself, but for some patients with relapsed follicular lymphoma, it can provide long periods of time when they do not have their disease come back. And we know a number of factors that may be predictive of who does better or who does worse. Patients who tend to fall into the high-risk FLIPI category, those that have had more than 3 regimens, and those who have follicular lymphoma grade 3, maybe those who, and particularly when all 3 of those factors are present, tend to do worse with this modality. There are other targeted strategies that have been utilized with stem cell transplantation that are helping to improve the outcomes beyond what I've shown you in the older CUP trial. And there are potential roles for incorporation of radioimmunotherapy and other modalities of therapy into stem cell transplantation to further improve these outcomes with autologous transplant. Of concern, though, still is the role of secondary myeloid cancers or myelodysplastic syndrome and AML, and these need to be considered in planning this and comparing this as an approach to other potential approaches that you'll hear about later on in the day from Steve Schuster, and some of the approaches that you heard about with chemotherapy previously. So next I'll turn to allogeneic stem cell transplant. So here with allogeneic stem cell transplant, we're facing another situation of comparing risk and reward. And this is a delicate balance in trying to maximize the benefit of the stem cells that you're getting in the graft with the potential harms from those stem cells. In this process, you're getting stem cells that are transplanted from another individual, preferably a sibling who is matched and related, or potentially an unrelated donor. For individuals who have a full sibling, the potential for each individual sibling is about 25% of finding a perfect match. For individuals within the United States, the average likelihood of finding a match is about 1 in 3 for looking for an unrelated donor. But here, the hopes and promise of using stem cells from another individual is that through those donor T cells, you can potentiate what's called a graft versus lymphoma effect. So having a new immune system that goes out there and recognizes the follicular lymphoma cells and kills those. Now we know that this is a process that is an ongoing process that can occur in patients with follicular lymphoma for a number of reasons. We know among patients who undergo watchful waiting that there is approximately a 2.6% incidence of patients actually undergoing spontaneous remission or spontaneous regression of their tumor. And that occurs probably in part because the patient's immune system recognizes those tumor cells and goes out and wipes them out. But for the vast majority of patients, that's something that doesn't occur. And so the hope is that with a new immune system from a new individual, that they can go out and recognize those tumor cells and wipe them out. But there are also potential downsides of that. In addition, those donor cells can go out and can wipe out or can attack normal parts of the body tissues and cause something called graft versus host disease, where those cells can attack the cells lining the GI tract and cause things like nausea or loss of appetite or diarrhea. They can attack the normal skin cells and cause rashes. They can sometimes affect the normal bone marrow, and they can sometimes affect the normal liver. And so graft versus host disease is one potential complication of allogeneic stem cell transplant that needs to be avoided. And one of the major challenges is balancing and trying to maximize the graft versus lymphoma effect and and minimize graft versus host disease. The other side of this equation is in the process of going through an allogeneic stem cell transplant, you first have to wipe out the normal T cells of the individual who's having the transplant. And those T cells potentially can reject the grafts or reject the graft and the immune system that's coming in from the donor. And when there's not an immune system, there's the potential risk for relapse. So these are more Kaplan-Meier curves that come from the International Bone Marrow Transplant Registry, which is a registry of data for patients who have undergone stem cell transplantation for a variety of conditions across the world. And what you can see here are data from this registry looking at patients who had autologous stem cell transplants that were unpurged, like in the CUP trial, and a relatively fewer number of patients who had autologous stem cell transplants with purged cells from across the world. And this just shows those Kaplan-Meier curves going down over 5 years with the adjusted probability of disease-free survival. And you can see here that at some time point that patients who had allogeneic stem cell transplant appeared to cross those curves. And there is some suggestion that there may be a plateau to this curve, which may suggest that some of these patients with allogeneic stem cell transplant are cured or are functionally cured of their lymphoma if you follow them over time with their follicular lymphoma. Although, as you can also see here, there were relatively fewer number of patients who had allogeneic stem cell transplant compared to autologous stem cell transplant. The other curves, though, that speak to this question are the overall survival curves, where you can see that there is a relatively steeper drop in the curve for allogeneic stem cell transplantation, so a higher risk of upfront death from this treatment, in part because of the toxicity of the regimens, some of which we have modified in ways that I'll talk about, but also because of the risks of graft versus host disease and other complications. And then on par out here, the survival appears to even out when compared to autologous stem cell transplant. And again, you can see this plateau in the curve. So one of the things that has led to that abrupt drop in the curve was the intensive chemotherapy that has been traditionally used as part of allogeneic stem cell transplant. And because of that, there have been efforts underway to try and reduce that chemotherapy or reduce the induction regimen for stem cell transplantation to reduce those risks up front. And so what you can see that there are really kind of two roles in allogeneic stem cell transplantation, both the pre-transplant chemotherapy and radiation to reduce the disease, and this whole process of the donor immune T cell response. Well, if this is an important response in getting rid of the disease, would it be possible to try and reduce this and reduce the side effects of chemotherapy and radiation, and then rely on the donor T cell response as the main way of eradicating disease? And that could potentially shorten the duration of having low blood counts, reduce the risks of upfront infection, and potentially maybe even reduce the risks of graft versus host disease. The other thing that this has allowed, and part of what I worked on when I was in Seattle, was trying to understand how this could best permit allogeneic stem cell transplantation for patients who might not otherwise be candidates. When we were conventionally using high-dose chemotherapy and stem cell transplantation for follicular lymphoma, we routinely said that for patients who are over the age of 55, that this would not be an appropriate therapy because the risks of transplant were too high. Now with these reduced intensity regimens, patients with follicular lymphoma and other low-grade malignancies are routinely undergoing these types of transplants even up into the age of 70. So I mentioned this role of reduced intensity conditioning as opposed to ablative or high-dose chemotherapy, but this really exists on a spectrum. There are relatively reduced intensity regimens where we're using lower doses of chemotherapy, but are still moderately intensive. These types of chemotherapy regimens, a regimen like fludarabine and melphalan, is still an ablative regimen, but much less intensive than these types of ablative regimens. And there are even attempts like what was done at the Fred Hutchinson in Seattle at trying to reduce the chemotherapy or radiation down to the very minimal levels so that you can just barely get the graft in and reduce the toxicity as much as possible. So TBI here is for total body irradiation. And so these are doses of total body irradiation of 200 centigrade. So these are the kinds of doses of radiation that any of us right now could walk in and get a dose and walk out and not notice that anything happened. And that has been combined with chemotherapy or with fludarabine chemotherapy as a way of being able to allow the stem cells to come in and to grow. And these show some data from the Seattle group, from Rainer Storb's group, looking at patients with indolent lymphoma. So this includes follicular lymphoma along with other indolent histologies, where you can see for patients who had no evidence of transformation that this looks to be a therapy that had long-term disease-free survival with a plateauing of the curve at about 45% to maybe as high as 50% of individuals who are out 5 years and are still alive after their stem cell transplant. Now, I think one of the things that's also important to consider when looking at curves like this is that these are very highly selected patients. So these are patients that come from all over the world and are able to travel to Seattle, to live in Seattle usually for 3 months to 6 months to sometimes even a year. And this does not necessarily represent the whole population of patients with indolent lymphomas or with follicular lymphoma. The other things to note is that there, like I showed you earlier for autologous stem cell transplant, there are factors that we can try to define that help us to predict who might do better or who might do worse with this therapy. And so when you're looking for predictors to see who does well in terms of overall survival, who relapses after their stem cell transplant, and who has other complications that lead to their death, there are factors that we can predict. One of these was a factor that I helped develop when I was in Seattle, this stem cell transplant comorbidity score index, where you can look at other kinds of factors that affect someone's health, like diabetes or heart disease or hypertension, and use those as predictors to see for whom this might be an appropriate therapy or not. And then some of these are disease-related factors, like the size of their lymph nodes. Some of these are related to the stem cell transplant itself, like how well the unrelated donor is matched to the patient. In terms of relapse, I showed you data on the risk of transformation, and that is something that definitely affects the potential benefit of this transplant. Sometimes this approach has been an approach that it was used in combination with an autologous transplant, where patients get an autologous stem cell transplant and then follow that by an allogeneic stem cell transplant. That was an approach that had been forwarded at times in the past and does not seem to be a successful approach, in part because often those were patients that had such poor risk disease that you might think of that as an approach. And some of the newer agents and some of the newer therapies that you'll hear about later on the day from Steve Schuster might be more appropriate for such patients. And that goes hand in hand with what we saw for patients who had refractory disease to chemotherapy. The MD Anderson group has been another group that is very much involved in the role of allogeneic stem cell transplantation for follicular lymphoma and chronic lymphocytic leukemia and other low-grade lymphomas. Issa Khoury has really been the leader of that approach. And this shows data from their approach at some of the complications that we talked about, the risks of graft versus host disease. With their approach, what you can see here is that has been relatively less than what we've experienced in the distant past, that for the vast majority of individuals, only about 10 to 11% of individuals had any form of detectable graft versus host disease. And when you look at the most severe forms of graft versus host disease, grade 3 and grade 4, that only about 2% of individuals over time had that kind of a problem. And so with the newer and more modern ways of doing reduced intensity conditioning and adding approaches like rituximab to the allogeneic stem cell transplant regimen, we've improved upon some of these outcomes. And you can see here the overall survival and progression-free survival for patients that were treated at their institution that was just recently updated and presented, that these appear to be quite favorable. But again, I caution you because these are also very highly selected patients for whom this therapy was selected. There are also newer and more modern ways of being able to apply other agents to this. So this looks at the role of radioimmunotherapy here, looking at ipilimumab tioxetan. I'm only going to say that once. In combination with rituximab, given both 14 days before the transplant as a test dose, and then as a treatment dose 7 days before the transplant, in combination with their traditional chemotherapy regimen. Now, while this is a relatively new approach and the data have been looked at in relatively few patients, this looks to be a very promising approach, particularly for patients who have resistant disease. So when you look at patients that were treated with this approach, including those who had sensitive disease and those who had resistant follicular lymphoma, and compare that to the earlier data that I showed you with their regimen, with relatively few patients, this appears to be quite promising. Another group that has forwarded approaches for the management of follicular lymphoma with allogeneic stem cell transplantation has been the Dana-Farber group. Their efforts have focused predominantly around sirolimus as a way of helping to prevent graft versus host disease. Now, one of the things that they saw to some degree by happenstance is that patients who had that as a mechanism to try and help prevent graft versus host disease actually did better in terms of keeping their follicular lymphoma away. And so this appears to have some other lymphoma-related effects. And here you can see in all of their patients who had this as an approach compared to those patients who had allogeneic stem cell transplant without sirolimus in terms of overall survival, and among those patients who had reduced intensity conditioning, it provided benefits compared to other forms for preventing graft versus host disease with immunosuppressive drugs. And that is an agent like radioimmunotherapy that is moving forward as an approach to improving outcomes for patients with allogeneic stem cell transplantation. So I've talked about autologous transplantation, and I've talked about allogeneic stem cell transplantation. So which is better, or which one should we choose? And this was an approach that was put forward by the Bone Marrow Transplant Clinical Trials Network in the United States to try and help to answer that question. Now, it didn't really attempt to answer that directly in a randomized trial, because what was discussed at the time the trial was being designed is that it would probably be very hard to do a true randomized trial for this particular situation, because patients tended to have relatively strong opinions about whether they would want to have an allogeneic stem cell transplant or an autologous stem cell transplant, as you can imagine from the things that I've described so far. But what was done was patients who had relapsed follicular lymphoma, including those up to the age of 75, and they had a sibling, but we did not yet know whether the sibling was a match or not, went into the trial and consented to this. And for patients who had a matched sibling, they went on to have a reduced intensity allogeneic stem cell transplant. And if it was found that that sibling was not a match, then they went on to have an autologous stem cell transplant. So this was really our best effort to try to address this question about which approach might be preferred for patients more broadly. Now, what you can see here is that although it was our best effort was not good enough. And what happened with this trial is that there were relatively few patients who actually consented and enrolled in this clinical trial. So only 30 patients in total. And 3 of those patients are patients that I put onto the trial. And so it's really surprising that one center would contribute to 10% of a trial in a trial that's a national trial. with a sample size that was this small, we really were unable to detect a real difference between these two approaches. And this was an approach that you can see here, that there was a broad splay of patients across these particular characteristics, and it was not really balanced well enough to be able to say something definitive about these two approaches. What we can see is that in terms of overall survival and progression-free survival, what the curves look like. Shown here is a relatively flat curve for patients who underwent allogeneic stem cell transplantation, and maybe some suggestions that there is a plateau, but this is still relatively too early to say anything about this approach, and there will be too few patients overall to say something definitive over the long term. So that really accentuates the importance of participating in clinical trials to be able to have access to good information for patients going forward. So who should be considered for allogeneic stem cell transplant? Well, based on what we know, this is really a therapy that is only appropriate for patients with relapsed follicular lymphoma. It's something that never should be used in the upfront setting. Patients typically are those who have failed at least 2 prior regimens and have had a relatively short period of disease control with chemotherapy-based approaches. Sometimes patients who have low blood counts or cytopenias, for whom you'd get an extra benefit of the allogeneic stem cell transplant by having a new marrow. Patients who tend to be younger were the ones that they was best suited for in the distant past when we were using high-dose therapy, but now healthy patients even up into their 70s, it might be appropriate when there aren't other good options. And I think it's very important to consider the comorbid diseases much more importantly than age. Age by itself has become less of an important factor for people who are 75 and healthy, or in their 70s and healthy. When I talk to patients about this and about other therapies in the relapse setting, I ask them about things like how long did their parents live, or what kinds of things are they involved in terms of their activities now. What other diseases or other health conditions are they also managing? And now with matched unrelated donor transplantation and the availability of a worldwide pool of donors, it's becoming less of a limitation for most patients. And we've started to see that the outcomes with unrelated donors are paralleling what we see with matched sibling donors for many types of transplant. So in summary, autologous stem cell transplant is an approach that can produce long-term disease-free survival in selected patients with chemosensitive disease. It is not a panacea, but for certain patients with follicular lymphoma, this is something that can provide a meaningful benefit. I think it is important to consider the concerns about secondary cancers that we heard about in the panel earlier. For patients for whom their disease is not responding to chemotherapy, allogeneic stem cell transplant may provide another modality that is potentially curative, but also has important side effects to consider. And there are newer modalities of therapy, some of which I mentioned, like radioimmunotherapy, or the incorporation of sirolimus or rapamycin, that may help to even further improve on the outcomes that we've seen with allotransplant. And with that, I'll stop, and I'm happy to take questions.